Synovial joints have a secondary classification, and the primary secondary classification is according to the shapes of the articular surfaces. Here we can see a ball and socket joint. This is the classic joint, for example the hip joint or the shoulder joint. In a ball and socket joint we have a biconcave socket and a biconvex ball. This type of socket will permit multi-axial movement. So in other words, it permits movement in all three cardinal planes, in a flexion and extension, abduction and adduction, and internal and external rotation. Sometimes we will find joints around the body that are condyloid in nature. And these look like ball and socket joints, but only permit motion about two axes. For example, the metacarpophalangeal joints here. Again, we have one surface is biconvex, the other surface is biconcave. But due to the organisation of ligaments, tendons and muscles, active movement can only occur into flexion and extension and ab and adduction at this particular joint. Rotation may be produced passively. In other words, if the therapist externally takes a hold of the joint, rotates one bone relative to the other, but this movement is usually limited by surrounding ligamentous structures. An ellipsoid joint, for example the wrist joint here, the anatomical wrist joint, is again another form of ball and socket joint where there is a biconcave component and a biconvex component. This time the ball and socket joint has been squashed about one of its axes, and so it looks elliptical in shape. Again, an ellipsoid joint only permits movement about two axes. For example, the anatomical wrist joint will permit flexion, extension, ab and adduction. We cannot actively rotate our wrist. A synovial hinge joint, as in the elbow for example, is a typical uniaxial joint. It only permits movement in one plane of motion. The articular surfaces are usually very congruent, and the joint is usually reinforced by a strong set of collateral ligaments to prevent any other movement, any rotational movement or any ab and adduction movement. A pivot joint is a joint that allows rotation about the long axis of the bone. For example, the superior and inferior radioulnar joints. In the superior radioulnar joint, we have an osteoligamentous ring that sits around the head of the radius. That then allows the radius to rotate about its long axis. Synovial plane joints, for example, the intercarpal joints of the hand or the intertarsal joints of the foot, are joints whereby the articular surfaces are flat or close to flat, and these permit small gliding movements. A synovial saddle joint, for example, the first carpo-metacarpal joint of the thumb, has articular surfaces that are concave in one plane and convex in the other. In other words, concavo-convex. The two articular surfaces are usually reciprocally shaped, and these permit biaxial motion. The role of joints is to permit movement. Joint movement may be active, for example, as a result of primary muscle action, or a joint may be passive as a result of external forces, for example, the therapist taking hold of a joint and flexing it or extending it, or gravity drawing the elbow towards extension. A movement that can be produced actively due to primary muscle action is known as a physiological movement. For example, flexion extension at the elbow, flexion extension at the shoulder, abduction at the shoulder. Occasionally, we will come across movements that are possible at a joint but cannot be produced in isolation by primary muscle action. These types of movements are known as accessory movements. For example, gliding movements at the elbow joint, longitudinal glides of the shoulder joint, rotational movements at the metacarpophalangeal joints. These movements are possible and they can be produced by the therapist externally or by external forces, but cannot be produced in isolation by primary muscle action. Accessory movements invariably are an essential component of a physiological movement. For example, gliding in an anteroposterior direction of the proximal phalanx of the fingers is essential for normal flexion and extension to occur. And a loss of an accessory glide can lead to a loss of physiological flexion and extension. As clinicians, we need to be able to differentiate between physiological movements and accessory movements. We also need to be able to identify which accessory movements are important for specific physiological actions. The joint may be placed into specific positions. You will hear people talk about the close packed and loose packed positions of the joint. The close packed position of a joint is the position whereby the articular surfaces are maximally congruent and the ligaments are tight. This is usually the position of greatest stability. Conversely, the loose packed position of the joint is where the articular surfaces are minimally congruent and the ligaments and overlying structures are slack. This is usually the most unstable position of a joint and is the position often that may lead to dislocation or subluxation. When revising joints, you will need to know all of the following in detail. You will need to know what classification the joint is, the primary and secondary classification. You will need to be able to describe the articular surfaces in detail, their shapes, how congruent they are, and what they are covered in, whether it's hyaline cartilage or fibrocartilage. You will need to describe the joint capsule, its attachments in detail, the extent of the capsule, and most importantly, the direction of fibres, as this will affect how a joint moves. You will need to describe the synovial membrane. You will need a good working knowledge of the ligaments. You will need to be able to identify every ligament, its proximal attachment, its distal attachment, the shape of the ligament, and the orientation of the ligament, and most importantly, the function of the ligament. In other words, the movements that that particular ligament will resist. Most ligaments will have a role in resisting more than one movement. You'd need to be able to describe the close packed and loose packed positions of the joint, identify the surface markings of the joint, and identify the movements, the normal physiological movements, the ranges and the limiting factors, and also the accessory movements associated with that joint.